Go ahead.
Yes, sir, sure. Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome our guest with great honor, none other than Dr. Rajesh Chandra Mishra, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD in Medicine, FNB, CCM, EDICM, FCCP, FCCM, FICCM, FICP, and consultant interest at Saiba Comprehensive Care Clinic, Ahmedabad. And today, sir is going to speak on a very important topic, that is antibiotic trap, avoiding unnecessary prescription on the occasion of World Antibiotic Awareness Week. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Stage is yours. You can proceed.
Thank you, Faz, and thank you, IJCP, for giving me this opportunity. I'm really honored to be here. So, in next 20 minutes, very precisely, we are going to discuss really the topic which I thought is: do you really need antibiotics in your patients? So, as time permits, I will giving you some scenario why antibiotics are not needed. This discussion is only pertaining to immunocompetent patient. We are not discussing anything about immunocompromised condition. Immunocompromised condition means somebody on immunosuppressive, somebody on steroid, somebody on post-transplant condition. These are the condition which is a different HIV patient or uncontrolled diabetic. We are discussing about immunocompetent patient when we do not need antibiotic. One of the first duties of physician is to educate the masses not to take medicine, and that's what we are here to do it. And I'm honored to do this job. So, reducing antibiotic use is the collective responsibility of the healthcare provider, patients, researchers, policymaker, even agriculture sector. Maximum antibiotic is being used in agriculture sector to have a healthy growth of plant for the animals, and that's where we get exposed to the microdose of antibiotic, leading to exposure, toxicity, and MDR infection, and general public potential impact. Whatever antibiotic exposure is happening today, that we expect that by 2050 the world will be having a pandemic which will be hit by pandemic resistant infection where we do not have any antibiotic to treat, so we will be squared to one. 10 million death happens annually, and about 100 trillion dollar cumulative economic loss happens due to MDR infection, and that's why it is concern for us. Few facts I'm going to discuss. It is often tempting to empirically administer antimicrobial or anti-inflammatory therapy like steroid in a patient with fever. Most of the time, we all know that first episode of fever in general for first 2 days in immunocompetent patient is due to viral infection, particularly upper respiratory tract infection, particularly acute gastroenteritis. These are the infection which is common, and they are mostly 9.9 out of 10 time are viral. But under loss of the patient, fear, or due to other fear, less access to the proper investigation, most of the time people start antibiotic, and that is one of the most mal-prescribed antibiotic which is happening and which should be avoided. Second thing, unless the patient has neutropenia, is severely immunocompromised, rapidly deteriorating in clinical status like MODS, multi-organ dysfunction syndrome, that is in ICU, antibiotic starting antibiotic is not a very high priority. We should be waiting for this. This is especially true, particularly the patient who has got undiagnosed fever only, no other symptom. If we give antibiotic, it really masks the disease, and many times, lot of infection which are can recover of its own. We think we falsely get assured that it has got better due to antibiotic, but that is not correct. So this is the thing. Therapeutic antimicrobial trials may confer a predisposition to resistance. How? They kill our normal microbiota, which are important for our survival. And killing those microbiota induces resistance because some of the bacteria get exposed to the antibiotic, they develop resistance and they multiply. And from there, a MDR commensal starts, and when our immunity goes down, we get infected. So, viral infection, which just needed to improve our immunity, which just needed to improve the care, they got bad because of the because of the inappropriate antimicrobial exposure. Even anti-inflammatory agent may lead to delay in diagnosis. It results in resolution of fever. So it is said that fever up to 101 degree is important and the body responds to combat the infection, and they take care of the infection. So better is that we should uh, we should not give antibiotic or even antibiotic even temperature is up to 101 degree, rather than giving antibiotic or antibiotic. Developing country need access to. So another reason for starting antibiotic is that people do not know what kind of infection it is. Everything is data, but for every patient is different. So we do not have very rapid access of the rapid point of care testing everywhere available, and that's why people start empirical treatment and thinking that is working, and that's the biggest drawback we have, and that is one of the strongest reason for using inappropriate antibiotic. We need to minimize the environmental impact of antibiotic. Antibiotics are being used for plant growth. Antibiotics are used for the good growth of the poultry or animal industry, where they are fed antibiotic for good growth of the flesh. So they can be used particularly for the people who eat non-vegetarian. Now the world is full of non-vegetarian, and all these animals are used for the slaughter and killing, but they need good growth of those animals for particularly muscle growth, and where antibiotic is used. Smaller the extent of exposure to antibiotic, less likely. So if you at all you have to use antibiotic, you should always decide that we should give it for lesser time. For if you are using empirically, maybe 3 days antibiotic is use is good. Post in surgical prophylaxis, most of the time 1 dose of antibiotic is good. Lot of pre and post procedure antibiotic is good, and even for most of infection, 3 to 5 days of antibiotic is good if at all needed, rather than continuing. The longer the exposure, more it will induce the resistance. So how we can reduce it? By just by educating people that taking antibiotic is equally dangerous the way you take any other medicine. It should not be taken over counter. It is like taking chemotherapy. Nobody will take chemotherapy in cancer unless you are confirmed diagnosis. So why we try to give antibiotic when diagnosis is not confirmed? It is a bacterial infection. Their use in animals should be limited to prophylaxis and therapy in a way that does not perpetuate the section of resistance. Even for animal also, if you really need, you need to give in when animal is infected, not just as a prophylaxis or not as for the good growth of muscle mass. Principle of antibiotic use is protection of the susceptible commensal bacteria in our environment for reversing the crisis. So all these we are doing to reduce the MDR emergence. When we I say MDR, it means multi-drug resistance. Did the history of antibiotic? There's a time when we did not have any antibiotic, and then golden age came when aminoglycoside came, macrolides came, penicillin came first before penicillin sulfonamide came, and over the time, antibiotic came. Along with antibiotic, bacteria became smarter and resistance came. So if you just see, first antibiotic came, and then along with antibiotic introduction, antibiotic resistance came. So penicillin was introduced, penicillin resistance came. Erythromycin group of antibiotic were introduced. So their resistance followed after couple of years. So bacteria were always very smart to induce resistance immediately after exposure of the after initiation of antibiotic. So this we know the fact. Whatever antibiotic we discover, bacteria will go smart. Bacteria will develop the resistance because bacteria are here to survive and live longer than us. We have to live with the bacteria. So better we live like commensal rather than inducing resistance and uh, 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 creating a problem. Creating a problem. So better do that. If you see our microbiota, genetically or due to environment, due to diet, due to lifestyle, everywhere we have some microbes. They live as a commensal, and they are needed for the health of that particular part of the body. Maybe it is stomach, maybe it is lung, maybe it is mouth. So we should be also aware that microbes are important in our body for their natural function. So if it is not there, that function get affected. Normal microbiota and commensal, they are important in fighting against resistance. So we do not need to kill our microbiota. And here is a picture of our microbiota. Our gut has bacteria, the different kind of bacteria in stomach, duodenum, jejunum, and colon. This is important to maintain the normal, healthy talk and healthy function of the all part of the body. So we have to remember that bacteria are our commensal and our friend, not enemy. What happened that in natural process there are sensitive bacteria which are commensal. When we give antibiotics not needed, they kill this sensitive bacteria, but along with killing, are not able to kill all the bacteria, and some of the bacteria develop resistance and they multiply, and then we get colonized with population of resistant bacteria. And here is the problem: these next time when our immunity goes down, we get infected with these resistant bugs. So selection of the disease resistant bacteria is like this mechanism of antimicrobial harm, that next time when our immunity goes down, we get infected, and that's where the problem, we think that from where this resistant bug has come. What is the importance of this phenomena in day-to-day practice? That we need to reduce the antibiotic use in human, in animal, and where in even in plant also. If we reduce antibiotic when not needed, how the bacteria develop resistance? Either they decrease the permeability, or there's a efflux of the drug when it is taken inside the cell, or enzymes get altered, or target site get altered. Same way happens in chemotherapy, same mechanism, and that is the reason we have different kind of chemotherapeutic drug, and we need to do the testing. And then, so if we compare the antibiotic with chemotherapeutic drug, mechanism remains same, treatment remains same, but chemotherapeutic drugs are used especially after testing the sensitivity, histopathology, sensitivity with the chemotherapeutic drug, and then chemotherapy is given where results come, or maybe results may not come depending upon the stage of tumor. Here, bacteria, we are so impatient and we start antibacterial just looking to the total count and fever, and which is the most dangerous thing we can do. What I can say that if you have a fever, if you have a high total count, try to find where the infection. In 1 day or 2 days, if you don't give antibiotic, nobody is going to die until unless patient has got multi-organ sepsis, that is organ dysfunction, or vital signs are deranged, like patient has breathing difficulty, or there is a hypotension, or patient has any organ dysfunction, or patient has got neutropenia. If it's a neutropenic sepsis, a different story. If these three conditions are not there, other parameters are normal, patient is immunocompetent, no harm in waiting 1 day or 2 day, or waiting for some time till we get confirmed. Many times we start antibiotic not needed. Patient has malaria, patient has scrub typhus which need doxycycline, patient has dengue fever. Most of the antibiotics are given in viral, and dengue is the most important culprit where people give all sorts of antibiotic, which is equally harmful for treating dengue patient. So uh, as I said, that we have to use antibiotic like chemotherapeutic drug, being specific, try to be specific, try to send culture, and then treat it. Like here is the case: 24-year immunocompetent patient, no comorbidity, male, has high grade fever up to 105, 24 hours, 3 episode, goes to GP, he starts fixing paracetamols, no response, come to me after 48 hours, high grade fever, body pain, no other symptom, no other manding. I stop all antibiotic. I only give paracetamol. Yes, paracetamol you have to give if your temperature is above 101 degree temperature to relieve this, not up to 101 degree. Above 101 degree in immunocompromised patient, because up to 101 degree temperature is needed to fight against germ. It is a body protective response. So if at all you have to give paracetamol, give it 1 gram 6 hourly, maximum 4 gram you can give if patient do not have liver dysfunction. So 650 paracetamol if you are using it can be given up to 4 hourly. Send the blood report. In particularly in our tropical country, we should first look for the fever. If upper respiratory symptom is not there, common viral cause like dengue, like malaria, like scrub, like leptospira, chikungunya, these are the common. And then any urine infection patient has, or any lung infection patient has. So these are the common thing. If you do almost 80-90% time, you are able to find the cause. You need to send the specific, like suppose if you are testing for dengue, doing NS1 IgM IgG in first 2 days of no use until a patient is previously infected. For dengue specific tests, do dengue PCR. So I sent dengue PCR because it was 48-hour time, and before that nothing was done. A basic CBC, ESR, CRP is requirement for any fever patient. Even if you are not doing any giving any treatment is okay. Send at least CBC, SR, CRP. Ask the patient to monitor the temperature, heart rate, blood pressure if you can monitor, and there's a basic thing in oxygen level. So that is more important than us giving any treatment, and inform you after 12 hour or 24 hour what is happening to treatment. And take plenty of water, take rest, that is more important. Switch on air conditioner so environment temperature is not high. In India, when patient come, fever come, everybody asks to stop everything, so fever will come, patient will defervescence and will have more symptom. So ask the patient to keep under control environment so he do not have more symptom. So I started paracetamol and send the as a routine protocol, send the test for the dengue, send test for malaria, that is QBC and antigen, send scrub typhus test. These are basic things we do, and then leptospira antibody IgM, and we found that patient has NS1 positive, dengue PCR as positive. So once dengue PCR are positive, we advise the patient to go for the rest, paracetamol 1 gram 6 hourly, temperature above 1 degree, and do CBC and APTT daily. Here I want to emphasize to this important crowd that dengue is a disease of endothelium. Let thrombocytopenia happens late. First thing happen, endothelium get affected, endotheliopathy happen, and then patient start bleeding tendency. To combat that, you need to do early APTT test. If APTT goes start going up and it goes above 1.5 times, you need to admit this patient early to avoid the complication of dengue and give FFP. Once you start giving FFP, it really counters lot of the factors which can happen due to coagulopathy, rather than giving waiting for thrombocytopenia and develop coagulopathy, giving more fluid, capillary leak syndrome and complication. So if you monitor CBC and APTT daily in dengue patient and NLDS, that is enough. If it is not deteriorating, let the patient be at home. If it is deteriorating, admit that. uh, is there any association of fever grade? Yes, if patient has fever between 102 to 103 degree, 104 degree, it's likely a bacterial. If it's above 105 or less than 101, likely it is a viral infection. You should always think for the intraparasitic infection, particularly malaria. This is very important. And then then malaria and scrub typhus. We should always think, because for scrub typhus, just giving doxycycline, it takes care of the lot of problem. WBC count really gives you a very good marker of diagnose between in bacterial and viral. If W total count is normal, particularly polymorphs are not very high, lymphocytes are going up initially, monocytes are going up initially, then it's likely viral infection. If even count is normal and uh, not neutrophil counts are going out of proportion like 80-90%, there can be a sign of bacterial infection. So just looking to the total count and looking to the neutrophil, lymphocyte, eosinophil, and basophil, you can really differentiate if you have not given antibiotic, any other drug, which type of fever it is. ESR-CRP will be not very high in viral infection, while in bacterial infection it will go up. Procalcitonin is of no use in initial phase, but it can be initial useful when patient is in sepsis. So procalcitonin should not be done as a routine test to differentiate between bacterial and viral. CBC, SR, CRP is more than infection. Tropical fever panel, particularly scrub typhus, leptospira, dengue, malaria, chikungunya, are compulsory in all patients who comes to you with fever to find the cause of fever, and this will really avoid misuse of lot of antibiotic. Many time in first 72 hours, you may not find positive of the leptospira or scrub. You need to repeat after a patient has come to you within 72 hours. So initial phase CBC and differential count and ESR-CRP is okay. If you do dengue PCR, even within 12 hours, if it is dengue, it will turn out positive. You can avoid lot of unnecessary antibiotic use. You can avoid lot of unnecessary use of the other medication and test if you have done this thing. So this is my advice for you. Myth to break is fever is synonymous with bacterial infection is absolutely wrong. Most common cause of fever is non-bacterial infection. High TLC means bacterial infection and sepsis. This is absolutely wrong. High TLC can happen in thousands of other. In most common causes, even early phase of viral TLC can initially as a reaction can go up. Trauma, any parasitic infection can increase TLC because of protective response. So don't treat every TLC as a bacterial infection and give antibiotic. It's a very very wrong approach. Normal TLC rule out infection sepsis is also correct. Immunocompromised patient can present to you with total anomaly count and maybe pancytopenia. Why to give antibiotic? In upper respiratory and flu, not needed. Acute gastroenteritis, most time it's not needed. They just need hydration. Dengue fever, absolutely no antibiotic is needed. It just needs paracetamol, monitoring. If an treatment, if patient cannot take orally, give IV fluid. If patient admit the patient, if patient goes into prolonged APTT, capillary leak phase, give it 50. Platelet count is only needed if platelet count less than 10,000. Most of the time, platelet count is not needed. And when you are seeing platelet, also look for the platelet volume. If mean platelet volume is high with low thrombocytopenia, you don't need to worry about thrombocytopenia too much. Most of the time, it is missing. Chikungunya, you just need to control the with paracetamol and hydroxychloroquine. Stroke, why do you need to give antibiotic? You just need a specific treatment for stroke. Catheterized patient, if you have done aseptic catheterization, they don't need any sort of antibiotic, even for foliage, even for intubation, even for central line. If you have done aseptic precaution, you don't need to do take antibiotic. Acute pancreatitis, you really don't need antibiotic for first 7 days until the patient has any other secondary infection. So these are the places where antibiotics are misused commonly. So delayed antibiotic inhalation is acceptable if patient is not in septic shock, not in multi-organ failure, not in neutropenic sepsis. How long antibiotic has to be given should be shortest, maybe up to 5 days is maximum. Rarely in meningitis, it can go up to 14 days or 3 weeks. Most of the infection and in gram-negative septicemia, which is MDR, where 10 days is okay. Otherwise, most of the time, 3 to 5 days antibiotic is enough. When to do, when waiting to start, what to do, monitor the patient. Control symptom, keep patient, hydrate the patient, let him take orally, monitor his CBC, monitor his ESR, CRP trend, monitor his vitals when you are not giving antibiotic. That is more appropriate and scientific approach rather than giving antibiotic and doing harm to the community. This is my last slide because I do not have time now. I have taken 20 minutes. Very important thing, we need to understand difference between infection and sepsis. So infection is a control risk. Whenever somebody get infection, a body gives control immunological response. They do not have a multi-organ, any organ dysfunction. They do not have tachypnea. They do not have lung involvement, or they do not have any other organ dysfunction, shocks, hypertension. Infection is called control immune response, where body is fighting and controlling the response. You have all the time in the world to find the cause and treat it accordingly. When patient goes in sepsis, sepsis is the uncontrolled immune response, where patient develop tachycardia, tachypnea, low blood pressure, or any organ dysfunction, brain, lung, and brain, like skeletal behavior, tachypnea, or shock is the most common, but it can have liver dysfunction, it can have gut dysfunction, anything can happen due to sepsis. So we need to differentiate between infection and sepsis, and also pinpoint the tropical infection from bacterial infection, because tropical infection in our country are very common. They typically present like bacterial infection. So if you can differentiate them and focus your approach more on infection, finding the cause, you can avoid unnecessary use of antibiotic. If you do not do that, you will be misusing a lot of antibiotic. There is a difference between control infection and this is the sepsis. Sepsis is uncontrolled infection. Most of the time, we want that our infection should be in control. That is, pro and anti-inflammatory should be equally, so patient do not go in uncontrolled phase. But in sepsis, it goes like pro-inflammatory response is more than anti-inflammatory. It's our body response, and that's where we develop multi-organ dysfunction syndrome. So I think I will stop here. That when you deal with infection, please try to find the cause of infection before starting antibiotic. If it is not shock, it's not organ dysfunction, it's not deterioration in general condition, you really don't need to worry too much about giving antibiotic. uh, Rather than trying to find the appropriate diagnosis is a better approach to avoid emergence of MDR pandemic, because we are just sitting at the door of multi-resistant pandemic, and which is going to create more havoc what COVID has done or what flu has done. So with this, thank you for your attention. I'm open for any question.
Thank you so much, sir, for your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I can see, sir, we have received some question. With all your permission, shall we take this?
Yeah, yeah. Please.
First question is from Subramaniam. He's asking, what are the most common condition leading to unnecessary antibiotic prescription in outpatient settings, sir?
Upper respiratory tract infection is the most common. Acute gastroenteritis is the second most common. Then fever with undifferentiated fever with body ache. There is viral infection. Like patient has dengue, patient has chikungunya, and where everybody writes antibiotic. So that's why I was repeatedly saying, please, we need to rule out these common causes to avoid use of antibiotic.
Thank you so much, sir, for answering this question. Moving forward, I can see another question from Dr. Sanjana, and she's asking, should regulatory authorities impose stricter oversight on antibiotic prescription, and what would be the implication of such measures, sir? What is your point of view on that, sir?
So, if regulatory authority put regulatory rule on antibiotic use, it will be great, but it should come with some caveats, like where regulation should be there. First thing, who can prescribe antibiotic, if that can happen, and if you are giving antibiotic, these are the things you should just only they need to do. Okay, first you test these things, like at least you do CBC. If you are giving antibiotic, at least you be sure that do imaging, send culture report, and then give antibiotic. Then it will be appropriate. And even in OPD practice, if you are giving antibiotic, at least you do CBCS or CRP. Try to confirm there is a bacterial infection, and if it is bacterial infection, from where it is, like suppose it is a cough, is sputum coming, send culture. If you think it's a urine infection, send at least urine infection. So it will be more specific in giving antibiotic. So regulatory regulation is must, because if it is not done, it's going to create havoc. But it should come with proper guideline that when you can use antibiotic and when you should not give antibiotic, and it should be followed strictly. That means a regulation should come. Then if you are giving antibiotic, you should have some proof to say that not only fever and total count, that patient has bacterial infection. If that caveats come, it will be great.
Thank you so much, sir, for sharing your insight on this question. I hope that it will very much impactful to all the viewers. So I can see, sir, there is no more questions, sir. I can see Dr. Subramaniam is writing impactful talk. I hope, sir, like he has really enjoyed this talk show. And sir, as there is no more questions, sir, with all your permission, shall we conclude this session, sir?
Thank you for the
And
opportunity,
take,
and I hope I could deliver a small message which I wanted to
yes, sir.
everybody. They may not to use antibiotic. That was all intention I had.
Yeah, sir. And take care, sir. We would like to see you in future also with different
Sure,
topics, sir. Thank you. Have
sure.
a great day.